We would like to thank the participants of this webcast for very informative, very good, very useful day, and we lost the signal. Can you hear us? Yes, we can hear you partially, and we are waiting for your question. We are ready to answer happily. We are really grateful for this opportunity to be a part of this webcast, for brilliant presentations. And of course, you made our day really great, very informative. We're very grateful to the organizers for this webcast. We had a question to Boris. What do you think? Patients with which anatomy of the anterior segment fit better for mixed surgery? I mean, open angle and mixed glaucoma or narrow angle. So in terms of anatomical parameters, the depth of anterior segment, the thickness, which patient portrait is optimal for MIGS surgery, M-I-G-S, MIGS surgery? Well, here we speak about combination of cataract extraction with microinvasive glaucoma surgery, MIGS, as you just designed it. So again, the term of microinvasive, at least in our institution, somehow we meant by microinvasive something different. Well, it was not permitting sclerectomy, and so we changed the parameters of a scleral flap. That's why we call it microinvasive. But in this case, well, it is simply not micro, but mini deep sclerotomy modification, I would call it, but MIGS, M-I-G-S, it's totally different category of intervention. But speaking about your question now, I believe these are open-angle patients. Yet this technology was tested exclusively for patients with open-angle OAG and even pseudo-exfoliative, and as our colleague just confirmed, was not included into the trials. Was not including. So the issues about the mixed, about the narrow angle or close angle, not yet discussed. So possibly, well, mixed, maybe somehow, but close angle possibly never. So it's definitely open angle. Thank you. And we have one more question from my colleague. Yes, I would like to thank Professor Kurusheva for brilliant organization. So a very interesting symposium. Thank you very much for that. Thank you very much for your patience. Yes, it was very nice to see these presentations, to listen to the global leaders in ophthalmology, best scientists, international guests and colleagues. Yes, very interesting. And I would like to ask a question to Professor Tam, but because he's not available, but Professor Stefan Milieu also touched some aspect of the angle closed glaucoma and the primary resectomy. For 20 years, we have been doing phaco primary as hypotensive surgery in closed angle, in angle closure. But before phaco, usually we perform is a iridectomy. So my question is, what do you think? Do we need to perform preliminary laser trabeculectomy before phaco to have IOP reduction as a result of phaco? So my question is to Professor Milieu. Thank you.
For the question, and actually, I have the same experience as you did. I started performing phacoemulsification also in clear lens more than 15 years ago. And like us, many other surgeons, and we all knew that it was working very well. You know, at least in our countries, it was more a sort of legal medical issue. Since in the guidelines, the primary phaco was not yet implemented, we were some way obliged to perform an iridotomy anyway. My suggestion is to suggest to suggest the patient to perform a phaco, and If the patient wants to think about, just in order to avoid any sort of problem, anyway, perform an iridotomy before performing a phaco. But in all of the patients where I perform an iridotomy, and the IOP is stabilized, I always suggest, please keep in mind that if you stay this way, it may happen in the future that the IOP comes up again. So I prefer to suggest you to perform a phaco, because once you perform a phaco, the situation is well solved in 90% of the cases. So this is the way I work in my department.
Вы удовлетворены ответом? Спасибо вам.
Are you satisfied with your answer? Well, thank you very much that you are with us till the end of the symposium, and thank you very much for a very valuable question. If possible, we would like to have a connection with Voronezh, because our people from Voronezh also wanted to ask something. Good evening. Yes, we are happy. Can you hear us? Can you hear us? So very similar question, our question. How is it important to have 24-hour IOP monitoring, and how it can influence the selection of medical treatment or microinvasive surgery? 24-hour IOP monitoring that can be mined with iClear, contact lens, or other tonometers. Thank you.
Well, 24 hours IOP monitoring is an old issue. Because there are groups who are studying the 24-hour pattern of IOP. The real story is that in clinical practice is simply unfeasible. So tell me in which place you can perform a 24-hour monitoring in a clinic. For sure not in our countries, not in European countries that I know, maybe Russia, but still I believe that it's not really feasible. But on top of that, I personally believe that if you want to take in the hospital a patient, you want to take measurements of the IOP, that means ask the patient to wake up, to go to the slit lamp and so on. You may introduce some confounders that may impact on IOP, and which is really very difficult to be interpreted. So in my personal experience, the 24 hours IOP monitoring, it does not simply exist. What about the
Мы хотели бы, чтобы он существовал, наверное, это фантастика.
We would like this 24-hour monitoring to exist, but probably this is the science fiction. Science fiction.
And also the new tools that should provide us values of IOP, just putting a contact lens on that is the Sensimed. I mean, I guess we can discuss for hours, but I can tell you that the company has hidden a number of information just because these informations were against their own interest. I can tell you this. So in our country, this technique doesn't exist at all.
Спасибо, коллеги. У вас есть еще вопрос?
Any other questions?
Следующий вопрос.
Yes, we have second question to ask. What is more effective for the IOP reduction? Fixed combination of the drugs, or possibly you can use different drugs from different vials? What I mean by that, what could be better? The compliance of the patient's washout effect and definitely toxic effect towards the surface of the eye. Thank you.
Well, I always look at this issue from the scientific standpoint. Let's start from the fixed combination that include a PG. That means latanoprost, travoprost, bimatoprost, or tafloprost plus the beta blockers. Okay. If you compare the efficacy of one of these to the prostaglandin alone, the difference is only statistically significant, but it's around 1 millimeter of mercury. And at least for the bimatoprost plus timolol, there was actually no difference at all. In fact, the EMA, that is the European agency, allowed this compound to be sold just because they wrote it may help in decreasing the secondary effect of the PG on the conjunctiva, decreasing the redness and so on. So, in fact, in the States, they don't exist. Why? Because they did not reach the difference in efficacy of at least 2 millimeters of mercury, which I believe it's really useful. For 1 millimeter of mercury, I don't think it may really make the difference. So I think that whenever you want to add something, in my personal opinion, I use the PG alone and I add something else, such as, for instance, the fixed combination of timolol and orzolamide, or timolol and brimonidine, whatever it is. The first one is, to me, is better than the second one, because by this way you may really achieve the best efficacy for your patient. Of course, with the fixed combination, such as Duotrav or Xalacom, whatever it is, you may improve the compliance of the patient, but anyway, you decrease the efficacy of the treatment. So at the end of the story, I don't know if what is better.
Спасибо, коллеги.
Thank you very much, dear colleagues. Any other questions? Yes, we have one more question. How many patients from your questions stay on monotherapy in 6 months, and how many require fixed combination prostaglandin plus timolol? Thank you.
It's very difficult to give you this number, but I have to tell you that the majority of the patients, anyway, have an associated therapy. I would say that 30–40% probably would stay on a prostaglandin alone, but all the others would have 2 or 3 drugs, 2 or 3 drops put together, because otherwise they don't achieve the target therapy that is necessary for their case.
Спасибо, коллеги, за ваши вопросы.
Thank you very much, dear colleagues, for your questions. I hope you are satisfied. My last question, Stefano, my last question. I promise. Well, the colleagues are interesting. Trabeculectomy. Is it still a golden standard? Can you say us yes or no?
Тогда к этому вопросу. А если надо делать ФАКО?
What about the following? What about FACO? If FACO is needed, do we have to do it simultaneously or consecutively? And if yes, what should be the interval in between, and what should go first and what should go second?
In my experience, I prefer to avoid combined surgery, not because it's difficult, it's not difficult at all, but because I always prefer to perform phaco first. Doing phaco first, I can achieve 2 issues. First, the eye is very well prepared for the subsequent trabe, in case I need to do it, trabe or deep sclerectomy, I mean for the filtering surgery. And second, anyway, the results, long-term results of the 2 procedures performed not simultaneously are better than those that you can achieve doing the combination surgery. Of course, there are rare cases where you are anyway obliged to perform a combined therapy. For instance, a patient with after an acute attack of glaucoma with synechia that are irreversible. In that case, you probably need to perform a combined surgery.
Спасибо.
Thank you very much. Well, colleagues, if you allow, very briefly, without the translation, I will try to answer these questions, and if needed, we will ask Stefano. So there was a question about prion diseases, and we got the question, yes, that's quite possibly that pseudoexfoliative glaucoma is a prion-like disease, and I also have the same position like Professor Rich, so the time will show. One more question, very many questions in fact, about the indications to FACO emulsification and in the treatment of pseudoexfoliative glaucoma. And today, maybe for the first time in our country, we put this question. Yes, it deserves attention. We find out that in the treatment of pseudoexfoliative glaucoma, what is very effective is early FACO. Very effective. And maybe even the removal of the transparent, of the clear lens extraction. And I hope that everybody already accepted that and agreed. Next question, one in the clinical case that was presented by the doctors, they did not operate her immediately. Well, this is definitely the question to Dr. Silva, and we had no time to answer it, but the answer is obvious, because the patient had central scotoma. Central scotoma, what IOP issue can be considered? They reduced by drops, by 15 millimeters. Speaking about magnesium as calcium antagonists, no multi-center studies were carried out, and I'm sure Professor Rich would tell you the same if he gets this question. So we cannot say that this is neuroprotective protector with the proven effect in terms of RCT. What's the role of perimetry 10 degrees? in the glaucoma diagnosis. Huge role, and I described it in my monography. And I do hope that we need to remember it more frequently, and we should speak about it because the macular changes starts very early in glaucoma, and that's why we can identify it only in the perimetry of the central area. Now, one more question, which Stefano answered. And our doctors are sending a very interesting question about monitoring. So perimetry in monitoring is very important. Visametin, I would like to ask this question to Stefano.
For mitochondrial dysfunction treatment, визаметин – это капли Скулачева, если
Visametin are so-called Skulachov drops, who is the dean of our Moscow University faculty.
we have one kind of treatment. It is called visametin, and this kind of treatment пытаются перевести. Доктора, можно я пока отвечу предварительно, потом спросим.
Can I answer preliminary? Well, no publications, no international publications about Skulachov drops, and probably the colleagues will never answer you about this drug, that it has some neuroprotective effects. So what's the problem of all Russian trials? Possibly we have some breakthrough ideas, but we never carry out randomized trials, and we don't publish our data abroad, and we don't have international standardized trials. So we don't publish anything. You are not known, and there is no future development. Can you translate it once again? So the question is about the Russian drug produced in Russia, which was positioned for the treatment of mitochondrial dysfunction and also for glaucoma treatment, which is called visametin. Have you ever heard about this drug, visametin?
But of course, I believe that anything that can positively affect the mitochondrial function would be fine also for glaucoma.
Вот такой ответ.
So that's the answer. Definitely, there should be experimental studies, phase 1, phase 2, phase 3, right, Boris? And only then we can be proud of Russian discoveries. Now, one question to Professor Tam, and let me answer instead of him, because the answer is very simple. What did he mean when he was speaking about the choroidal pressure? Because no one in our country is dealing with this problem, but the thickness of choroidea can be measured, and it's done very actively abroad. Here, this choroidal infusion is as well, when choroidea volume is increased and the angle is closed and the pressure is increased. So that's one of the mechanisms of closure angle glaucoma. Speaking about cognitive functions and the treatment of variability, perimetry can be done to the elderly, and whether it's significant. Unfortunately, nothing else is invented for glaucoma monitoring, but when we repeat the study and when we train the patient properly how to perform the procedure, then it can be pretty reliable. So please don't neglect and try to make as many as possible perimetries and to use GPA analysis for the assessment of progression. Yes, here are the main questions. Any other questions from the audience? Well, I'm very grateful for your patience and for your attention, because yes, this is a very difficult symposium, and I believe that there was a lot of information. Now we have to digest it, but at the same time, I believe we heard many new things from our colleagues. Boris, would you like to say something at the end? Yes. I would like to join the position of all speakers who are today here, that really this symposium was very interesting, very informative. Many new things. I personally myself got many interesting things from the presentations, from the reports, from the discussions. So yes, Professor Kurusheva, many thanks for all those efforts you invested into the organization of this event. I know it was not very easy, very simple to organize it, to get us together, lecturers and doctors and participants, and to provide the webcast. And that is why, yes, really, we are very grateful. And we value your organizational capacities for giving us this opportunity to participate and be invited. It's an honor to me. Yes, wrapping up, I would like to wish Natalia never stop at this symposium number 6, and hopefully we will meet again 1 year later. And thank you very much.